All right, hello running crew. We haven't done this in several months now. Lyndsay and I think it's been 2 or 3 months, so we're going to be a little rusty. Don't judge us. We've gotten a lot of great feedback from a lot of people who are continuing to jump in and do the 6-week strength and conditioning program that we published out, I think, starting in March. There's been one question that's been coming through pretty consistently, and that's been asking us, what do we look for when we're looking at running biomechanics? This can become a very complicated question because it really is predicated on how well you can look at the biomechanics of a runner to really then help influence what we can do individually to make those biomechanical changes. I will say that a lot of what we built into the 6-week strength and conditioning program are exercises and exercise clusters that we already utilize to help influence and correct some of the main biomechanical dysfunctions that we see in a lot of the runners that come into our facility. However, if you do a very specific biomechanical analysis of your form using a local running specialist within your community, then you can be very, very specific with what you need to improve upon and what the program looks like for you to do on a consistent basis to start to make those changes and those shifts in your strength, in your stability strategies, in your joint positions, in your posture, and all of those good things. So Lyndsay and I are going to go through 2 different layers of what biomechanical analysis might look like. We are going to be using our DIERS system. Our DIERS system is a high-fidelity biomechanical comprehensive integrated system where we're looking at slow motion video analysis from the frontal plane, from the sagittal plane, from the right and the left, a posterior view as well for slow motion video analysis. It has a pressure plate within a high-speed treadmill. It has a 3D spinal modeling capability using a technology called raster stereography, which has been developed about 20 years ago and has been used for a lot of medical research and medical spine interventions. So that's going to be kind of what we use, but we're going to do this in 2 layers. The first layer is going to be something that you could reasonably do with an iPad, or your local sports physical therapist or your local running specialist can do with an iPad. And the second layer, we're going to dive really deep into the weeds and look at some things that we think are really cool and really influential, that we are lucky enough to have the capability to look at within our biomechanics lab. I think that is where I am going to exit, and I am going to turn it over to Lyndsay, and she is going to tell you a little bit more specifically what we're going to be looking at in both those layers of biomechanical interpretation. Yeah. Take it away.
So, like Dave mentioned, we're going to kind of break it up into 2 different sections. Being the first is that, you know, if you were to go into your local sports PT in the area, that they could pull out an iPad and essentially use an app like Huddle Technique to break down and look at the mechanics of your movement. And then the second portion, we're going to do a deeper dive using our DIERS motion analysis system here at PACE to really get some good objective numbers on gait mechanics and kind of create this comprehensive analysis of what we look for when we have runners come in to get tested, whether we're using the iPad or the DIERS system that we have at PACE. So if we're breaking down and looking at running gait and running analysis, we're looking really at 2 different planes. So we're looking at the frontal plane, and the frontal plane is a side-to-side plane, so where our hips and knees are in space from the side. And then we're looking at the sagittal plane, which is our forward and backwards plane. So with the frontal plane, we're looking at a couple of different things with loading. We want to see what your hips and legs are doing along with your trunk as you're loading in this kind of side-to-side plane. And as we do a deeper dive into my gait analysis, which is who we'll be looking at today, you'll see a couple of things that are pretty consistent with what we saw in our 6-week strength and conditioning program. And if you guys can jog your memory, there were some things coming up where my right side was weaker and I had a harder time loading on my right side. So again, that's looking at that frontal plane, and we'll see what our hips do when running. The second plane we're going to look at is our sagittal plane, and we look at this plane to really kind of interpret both power, but what our feet are doing when they're landing under us as we're about to go into a turnover. So we're looking at initial contact, which is when we first, when our foot first strikes the ground. We're looking at mid stance, which is when our foot is directly under our pelvis, and we want to see some objective data and numbers in terms of angles as to what our hip is doing, our knee is doing, and what our ankle is doing during that time. And then toe off, which is as soon as we push off of the ground, it's our power phase, right? So we want to see too what our ankle is doing in accordance with knee and hip as well on the sagittal plane. If we come over here, there's a couple of things that we know that we can change right off the bat if we're just looking at cadence. Now, cadence is how quickly your foot's kind of striking the ground while you're running. So optimally, we want to see around 180 steps per minute. So that's kind of the cadence that we're trying to get. We tend to see this fluctuates a little bit, but 180 is what we tend to see in the research that is the best to optimize our performance when running. So if we're hitting around 180 strikes per minute, right, there's a couple of things that we can easily change just by trying to hit that 180. So we're going to see a vertical displacement of your center of mass comes down, right? So we don't want to see a ton of up and down. That's a waste of energy. So we want to try to be efficient in moving forward and not waste a ton of energy coming up and down. We want to see hip adduction and internal rotation come down. So we'll see this on my test, but adduction is essentially where our knee kind of drops in, right? And then internal rotation is what our femur is doing when our femur internally rotates with that adduction that's happening. So that will come down if we kind of ramp up the cadence a little bit. Decreased knee loading, decreased impact force, both of those kind of go hand in hand, right? Increased glute activity at initial contact. So as we come and strike the ground, our glutes going to be working a little bit better for us if our cadence is a little bit higher, around that 180. Decreased braking force and decreased overstriding. So if our turnover is a little bit quicker, if we're hitting 180, we're not going to be overstriding and landing with our foot way in front of our body. Okay, so it's going to land a little bit more directly under us because we're trying to hit the ground and get off of the ground a little bit quicker when we hit that 180. So those are a couple of things, if you integrate that right now kind of into your runs, these are some things that we'll start to see change if you're shooting for about 175, 180. That's kind of the main breakdown. So we'll take a step back from this and we'll kind of do a deeper dive into biomechanics on the DIERS system now.
Hello, running audience. We are now looking at our DIERS system. And this is the landing page. I'm going to unpackage this a little bit, and then I'm going to turn it over to Lyndsay. She'll tell you a little bit about her running injury history, and then we'll dive into the two different layers of biomechanical analysis. The first one being things that your local sports physical therapist or running specialist will be able to do with an iPad. And then the second layer is going to be what we have the fortunate capabilities of doing here in our biomechanics lab with our DIERS system. So what we're looking at here is the landing page of one of the high fidelity running assessments. And the components that we have turned on for this particular study, we have on the 3D spinal model that we're going to look at in the second layer of interpretation. We have on our pressure plate data in our high-speed treadmill, which we're going to look at in the second layer of our biomechanical interpretation. Then we have slow motion video analysis from the right and the left. So this is where we're going to look at our sagittal plane mechanics. And then our frontal plane here from the anterior, and then we're going to spend a little bit of time looking posterior as well. And we'll point out some things that we don't necessarily love about Lyndsay's biomechanics. We're going to clearly make a lot of fun of her because we've done that over the 6-week strength and conditioning program, so we need to keep that going. And then we'll also pick out some things, or we'll point out some things that we have seen increase the likelihood of injury in other runners, or in all of our runners. So Lyndsay's going to take it away and talk a little bit about her injury history, just to give a little context as to what we're looking at and why it's important.
Yeah, so history-wise, and more so in the history of my injuries, I've had a couple of things occur over the past probably like 10 years or so. Most recently, and the mechanics will explain as to probably why I've had some of the injuries that I've had, but most recently I've had some left patellar pain, so some kneecap pain on my left hand side right here, and then I also have a history of shin splints. I have a history of a right tibial fracture, so this was probably 8 to 10 years ago now, but on my right side I had a fracture right through this bone here, stress fracture. From running. I have a history of, on my longer runs, so anything probably over 8 miles or so, my right inside of my ankle, so right through kind of here, right where our posterior tibialis tendon comes through, starts to feel pretty strained and overloaded, and in addition, my low back starts to hurt, which we'll talk about that a little bit as well, but those are probably the main things that I continue to have to be aware of and conscious of, with the most recent being that left knee pain, but that's gotten a little bit, it's gotten better, so.
Cool. All right, so we're going to first jump into a deep dive into the frontal plane. So we're going to look at this anterior view first. We'll spend a little bit of time looking at the posterior view, and then we'll look at the sagittal view as we do this first layer of biomechanical interpretation. So as we go to the frontal view, we'll back this up, and we're going to go frame by frame. So just to give you a little bit of orientation as to what we are looking at, we have these little reflective dots placed on certain bony landmarks of the body, and these are things that you can actually also capture with an iPad and some slow motion video analysis software like the Huddle technique, like Lyndsay had said. You won't have the fancy dots, but you have the capability of making a lot of these joint angles. They might not be as accurate as what we can do here with our biomechanical system, but you don't need to be terribly accurate to do a thorough biomechanical analysis for the sake of improving your biomechanics. So this dot right here is a reflective dot placed on the ASIS, which is the bony prominence on the front of the right and the left side of your pelvis. You can probably feel this on yourself. It's right where your belt is. We have a dot right on top of the kneecap. We have a dot right on a bony prominence right under the kneecap, a bone called the tibial tuberosity, and then we have a dot right in the front of the ankle, kind of midway between the medial and the lateral side of the ankle. So what you'll see is as we start to go forward, angles will appear, and these are the same angles that you can generate on an iPad, and we can get a sense of the pelvic position and where it is in relationship to horizontal. We can look at hip adduction position, or how much of an inward angulation we have of the femur in relationship to the pelvis. And we can look at the knee valgus or varus angle, or how much the knee is bowing in towards midline or bowing out away from midline as we're going into loading. There are certain things that we want to see in these numbers, and there are certainly some things that we don't want to see that we know from a large body of research increase the likelihood of injury. So we know that Lyndsay already has some right-sided issues, so we're going to fly through that. We're going to look at the left side first, and we'll point out some things. And we're not going to spend much time looking at what's happening at initial contact. We do that sometimes in here. But for the sake of brevity, we're going to look only at peak vertical impact force, which happens at mid-stance. So at mid-stance, there are certain things that we want to see and certain things that we don't want to see. What we want to see is we want to see the pelvis stay relatively horizontal to the world. We're going to get a little bit of what we call a contralateral pelvic drop. So as we load the left leg, the right side of the pelvis is going to drop down a little bit. That's an appropriate kind of mechanical manifestation of the body helping to attenuate that vertical impact force. We don't want to see that excessive. This can be kind of hard to measure on an iPad. You can certainly get an approximation. We are going to look at that more closely when we do the second layer of interpretation as we look at our raster stereographer information. We also don't want to see a big angulation of the femur in relationship to the pelvis, or what we call hip adduction. What we've identified in a lot of our runners is that we don't want to see much more than 12 degrees of an adduction collapse in our women. We don't want to see much more than 10 degrees in our men. The reason that there's a difference is because the architecture of the female pelvis is a little bit wider, so it's going to change some of these angles. So we don't want to see much more than 12 degrees in our women. Lyndsay is already at 14 degrees, so she's getting a little bit of an excessive adduction collapse during mid-stance. So that's something that we would want to fix with a lot of hip abduction and external rotation strength, which are things that you have already been doing if you've been doing the 6-week strength and conditioning program. Her knee right now is at 171 degrees, so 180 degrees would be totally straight. 171 degrees, which is 9 degrees away from straight, means that she is in 9 degrees of a valgus collapse, which is more than we would like to see. So this is putting some strain on the knee. It's introducing a little bit of internal torsion through the tibia. Her hip abduction or adduction collapse is going to increase the likelihood of IT band issues, which we have actually worked on recently with her on this left side. So these are things that we are really focused on when we're looking at the frontal plane loading mechanics on the right and the left side. We're going to go to the right side, which we know in Lyndsay was the leg that she had a harder time stabilizing when she was doing single leg stability work in the 6-week strength and conditioning program. And we also know that she had more weakness in the back of that right hip with some of the exercises. So as she goes into the loading phase on this right side, we'll see that things get substantially worse. Her pelvis stays pretty neutral, which is great, but her hip adduction collapse is 15, which is far more than we would like to see. Her knee valgus collapse is about 13 degrees right now, which is far more than we would like to see, almost twice as much as we would like to see. And because the foot is on the ground and the body is really moving around this stable foot, it means that these numbers right here are pretty well tethered together. So the more hip adduction collapse we get, the more knee valgus collapse we're also going to get. So these two are going to increase and decrease at normally a similar proportion. So she's showing that she's at least mechanically demonstrating that she has less strength in hip abduction and external rotation, or she has a latency of contraction, or she has something going on where she's not able to stabilize against that internal rotation and frontal plane collapse of this right leg. So these are things that we would absolutely want to correct in her. Lyndsay, do you want to add anything to frontal plane?
No. Yeah, I mean, I think the big things are just considering that the test is confirming that my right side's a little bit weaker, that I internally rotate my femur a little bit more, which is consistent with the fact that when I was loading in single leg exercise during the 6-week strength and conditioning, that I felt more unsteady. I could feel my glute and hip abductors weren't working as much for me. So yeah.
Cool. All right, so we're going to stay in this plane, but we're going to look from the posterior view, and we're going to only look at foot and ankle mechanics and lower extremity mechanics here, because we've already looked at what's going on at the knee and the hip. So we're just going to focus on 2 numbers down here. And the numbers that we're going to look at, if we take a line and we draw it through what we call the calcaneal bisection. So we have a dot on the base of the calcaneus. We have a dot on the superior aspect of the calcaneus, or of the rear foot. If we draw a line straight through there, we're going to look at that line in relationship to vertical. Right now we can tell that she's 3 degrees of a collapse inward from vertical. So we're going to talk about the significance of that here in a second. The other number that we're going to look at is the Achilles angle. So if we take a line and we draw it through that superior aspect of the calcaneus, and we draw a line straight through the midbelly of the Achilles, if we look at that line in relationship to the calcaneal bisection line, we have 11 degrees of discrepancy. So that's called the Achilles angle. So let's go through to the left side first, and then we'll come back to the right side. So as she goes into loading, and we are going to look at that Achilles angle. So now she's 16 degrees inverted. The Achilles angle is at 11 degrees. So as she loads, we know that we're going to get peak vertical loading at about mid-stance. So as she's going from initial contact into loading, we can see that that calcaneus is going from an inversion position to more of a vertical position. So now she's 3 degrees from vertical, still in a little bit of inversion. And we're going to continue to go forward. Now she's straight up and down, so she's totally vertical. And if we go a little bit more, she stays vertical. So that's pretty good. That's actually what we want to see. So she has a vertical calcaneus at mid-stance, and then the relationship between the calcaneal bisection and the Achilles bisection is only 4 degrees. So in my mind, and what we have seen in our biomechanics lab over the last couple of years, is that minimizing that Achilles angle is going to help minimize the vulnerability of Achilles tendonitis or Achilles tendinopathies, and also tibialis posterior issues, plantar fascia issues. So the loading mechanics through her rear foot on this left side look pretty good. Calcaneus is vertical, Achilles angle is only 4 degrees. We don't want to see this much more than 8 degrees. And we don't want to see the calcaneus collapse much more than, I would love to see it at 0. We don't want to see it collapse into eversion, and we're going to see that on the right side. So as she loads the right leg, and we look at those same 2 angles, now that she's at mid-stance on the right side, we can see that the calcaneal bisection is 3 degrees collapsed into eversion. So she's 3 degrees beyond neutral. And we can also tell that the Achilles angle is 11 degrees, which is higher than we would like to see it. And this is something that, as we said, biomechanically increases the vulnerability of Achilles or Achilles tendonitis issues or tendinopathies, and tibialis posterior, which is that muscle and tendon structure that helps support the midfoot, helps support your arch. So in this position, she's putting a lot of strain in that tibialis posterior, and that's where she actually feels a lot of her soreness during her long runs once she hits a fatigue point. So this is something that we can absolutely correct with some strength and conditioning work. We can potentially correct this with modifying her cadence if her cadence is particularly low, if it's less than 170 and certainly less than 160. If all of those attempts at improving her biomechanics aren't totally effective, then it might be worth considering a different shoe that helps provide a little bit more support, or even maybe some orthotics that help support her foot a little bit if she's going to be doing a lot of running. So those are the main things that we look at in the frontal plane. Lyndsay, do you want to chime in on any of that stuff, or did I hit it all?
I just want to say that my cadence is impeccable, so you can't shame me on that.
Okay, Lyndsay's cadence is impeccable. She's 180 every minute
I'm
of every
180
run.
every minute of every run.
Okay, so she's unfixable. So she's broken goods.
So good luck, Dave.
All right, so now we're going to look at the sagittal view, and we're going to look at those three phases. We're going to look at initial contact, we're going to look at mid stance, and we're going to look at toe off. So we will go forward until we hit initial contact. So on this left or on this right side, when we're using an iPad, we don't have the luxury of having a pressure plate. So for us, we can go to our pressure plate and see that she is actually making initial contact right here. So that would be initial contact on that right side. When you're using an iPad, you just have to approximate where you start to see deformation of the foam of the shoe, and your running specialist is going to help do that. So at initial contact, we're looking at a couple of different things. Let me give you another orientation of this page. So this is a dot right on the greater trochanter, which is the bony prominence on the outside of your hip, which you'd be able to feel. It's just probably a couple of inches below your belt line. This is a dot right on the lateral side of your knee. We have a dot down on the lateral malleolus, which is the bony prominence on the outside of your ankle. We have a dot right below that on the calcaneus, and then we have a dot up on what's called the fifth styloid process, or that lateral bony protuberance on the outside of your foot. From this, we can get angulation of the hip in relationship to vertical. So right now she's in 18 degrees of hip flexion, and that's in relationship to vertical. We have knee flexion, and we have ankle plantar flexion and dorsiflexion angles. So at initial contact, there are several things that we want to see. One, we want to see that the tibia is within 10 degrees of vertical. So she's a little bit inclined beyond vertical, which is actually good. I would prefer that as opposed to her being a little bit declined from vertical. But we want to see the tibia relatively vertical at initial contact. We also want to see that if we draw a line straight down from the front of her pelvis, that it actually bisects her foot. So a vertical line from the front of her pelvis, we want to see bisect her foot. That just lets us know that she's likely not overstriding. And if we look more specifically at angles, so if we come down here to this chart, we have our hip angle, we have our knee angle, and we have our ankle angle. So at initial contact, she has about 18 degrees of hip flexion, which is pretty good. We don't want to see much more than 20. So she's within the range that we actually like. Her knee flexion angle is at about 21 degrees. We don't want to see that less than 10. Less than 10 degrees means that her knee is really stiff, and it's not in a good preparation to really absorb her body weight crashing down against the ground. So we like that knee flexion angle. And your physical therapist or your running specialist is going to know all of these ranges as well. And they might have slightly different ranges that they're looking for based on the mechanics that they're trying to optimize, and that's totally fine. This is just what we use within our lab and with all of our Nike athletes. The ankle angle, right now she's in 4 degrees of plantar flexion, so that means that she is 4 degrees kind of up on her toe, I guess, from neutral would be a way to kind of explain that. And that's what we like to see as well. We are not terribly concerned about somebody being a heel striker. Heel strikers have been given a bad name, but what we do know is we don't want the ankle to be more than about 10 degrees of dorsiflexion, because if you have a foot that's really dorsiflexed and you're landing really hard on the back of the heel, that can be an indication that you're overstriding, which is going to put a lot of braking force through your entire system, which mechanically is not very efficient and also introduces a lot of deleterious kind of loading forces that tissues and bones don't necessarily like. So at initial contact, we like what we see on this right side. And as we go into mid stance, and we are going to define mid stance as where she gets peak knee flexion. And she's going to get peak knee flexion right about when the foot is directly under her pelvis. So we're going to come down here and look at this number right here, which is our knee flexion extension angle. And we're going to go forward until we have the highest number, which means peak knee flexion, which on the right side is 46 degrees. So at mid-stance, her knee angle is 46 degrees. That's a little bit excessive. I'd like to see that better. In most of our recreational runners and competitive runners that aren't quite at the elite level, about 40 degrees is kind of what we want to see, around 40 degrees. In a lot of our Nike runners and professional runners that we have coming through our biomechanics lab, we see closer to 35 degrees in most of them. What professional runners do really well is they can maintain a lot of functional rigidity through their body and through their legs to help really capture a lot of elastic plyometric capabilities of soft tissue. If you're not quite elite and you don't have thousands and thousands of miles of training history and incredible amounts of durability, soft tissue durability, we see more like 40 degrees of knee flexion at mid-stance. And that just allows the hip, knee, and the ankle to really help capture that vertical impact force to kind of decelerate all of that load to help minimize tissue stress over the course of the run. So she's a little bit excessive. 46 degrees is a little bit excessive. I think that puts a little bit of an excessive load through the patellofemoral joint and just puts a lot of strain through the quad. It also makes it really challenging for the hamstring and the glutes to pull her leg through. We're going to look at that in the second layer of biomechanical interpretation when we start to look at these graphs over here. But we can't do that with the iPad, so we're going to skip that for now. Her ankle angle is 12 degrees of dorsiflexion. This becomes a challenge because looking at thousands of runners in our biomechanics lab, ankle dorsiflexion angle at mid-stance can range anywhere from 4 to 5 degrees in some of our elite runners, all the way up to 15 to 16 degrees. We haven't seen anything anecdotally to suggest that the amount of dorsiflexion at mid-stance contributes to injury, but what we have seen is that an asynchronicity of ankle and knee mechanics actually does increase likelihood of Achilles injury. That's a little bit more complicated biomechanics and one that we are going to hit when we look at the second layer of biomechanical interpretation. But because we can't look at that in the iPad, we're going to skip that for this section of the video. The main thing is that 46 degrees is a little bit high in that loading phase for Lyndsay. As we go from the mid-stance to toe off, so we're going to progress forward to where the toe is about to leave the ground. Things that we like to look at are how much hip extension that the runner is getting, how much knee extension the runner is getting, and that they're getting some ankle plantar flexion at toe off, because we know that that's going to optimize performance and it's going to increase stride length. So her hip extension angle right now is at about 24 degrees. We can see that here in the picture. We can also see it down here in this chart. And this is 24 degrees of extension in relationship to vertical. This is not 24 degrees of extension in relationship to the pelvis. So what we can see in Lyndsay is that if we can visualize, and this might be tough on a small screen, if we can visualize kind of the line of her pants, we can see that her pelvis is fairly anteriorly rotated, which means that she's getting a lot of extension in her lumbar spine, which means that a lot of this hip extension angle, 24 degrees, is likely not coming from hip extension of the hip itself, but it's coming from her reorienting her pelvis into anterior rotation and then having a lot of lumbar extension as a consequence. And we know that clinically, because we've had Lyndsay on the table, that she has really tight hip flexors, both on the right and the left side equally. So it looks like she's getting good hip extension, but a lot of that is coming from faulty pelvis and lumbar spine mechanics. So for her, we're going to want to really increase her hip extension range of motion by working on her hip flexor flexibility, and that's something that we already hit quite a bit in the strength and conditioning program, and something that she continues to work on. When she doesn't have a client here in the clinic, she's out stretching her hip flexors. And then I walk out there and I shame her for having tight hip flexors just to give her more motivation to continue to stretch.
That is true. That is not a lie. That happens.
And another good point is that everything that we're looking at biomechanically, it has better context if you've also had a very thorough clinical evaluation. So because we've actually had Lyndsay on the table and we know where she's tight, we know where she's weak, we know what joints are functioning well and what joints are not, and we know her injury history, that gives us a lot of context to figure out why she has biomechanical dysfunctions. So as you go in to see your local sports specialist, your local running specialist, they will do a clinical evaluation in addition to doing a biomechanical evaluation, because those two things together really give you the full picture of how you need to affect your biomechanics, increase your durability, and decrease your injury potential and increase your mechanical efficiency and improve your performance potential. Cool. So that's what we look at in the sagittal plane. Lyndsay, did you want to add anything?
No, I think Dave, you bring up a good point, and that this does not replace our clinical examination. This only is an adjunct to it and allows us to further dive into, you know, why maybe someone is having the injuries that they're continuing to have, or, you know, if we're having someone come in who wants to shave a couple of seconds or minutes off of a race, this allows us to put some objective data on where maybe things are falling apart a little bit, and then we can come back and retest them in a couple of months after they've been doing their exercises based off of both the clinical exam on the table and what we see here, and then kind of piece together the pieces of the puzzle to create like a really comprehensive strength and conditioning program for them.
Cool. So that is everything that I think that we're going to cover in the first layer of the biomechanical analysis. So maybe our video guy, once we send this to him, will flash up some cool screen that says that we're now going into the second layer of more detailed biomechanical analysis. We'll see if he can pull that off. And we're going to start looking at things with a much finer toothed comb. So here we go into that. So we're going to come back to our file of tests. And the first thing that we do when we do a high performance biomechanical video analysis using our DIERS system is we want to get a good sense of spine position in standing. We want to see what happens with spine and pelvic mechanics during walking, and then we'll do a much deeper dive into the running assessment that we just touched on in the previous section. So we will go to the 40 average. So this is her just standing on the treadmill, and we'll see this as it pops up. So she is just standing on the treadmill, and the raster stereographer, which is the technology that helps create the 3D spinal modeling, it uses surface topography and a bunch of complicated mathematical algorithms and equations to create a 3D representation of the spine. And that has been tested against x-rays and a lot of different studies to show that the accuracy of the 3D spinal modeling that we get from the raster stereographer is within 2 degrees of motion for each vertebrae in all 3 planes: the flexion extension plane, the side bending plane, and the rotational plane, which is called the transverse plane. So we can have a high degree of certainty that what we're looking at is what the athlete actually is presenting with. So we're going to do a little orientation of what we're looking at, and then we'll dive into her specific spinal mechanics. So actually, let's back up. Okay, we're going to back out of this for a second. We're going to pull up a different version. All right. So orientation. This little yellow dot on the left and the little yellow dot on the right are the PSIS bones, posterior superior iliac spine. If you feel on your back, right at your belt line, you'll have 2 prominent bones on the right and the left side of your pelvis. That's what these are. The bone right in the middle of those right and the left side of the ilium or the pelvis is the sacrum, the big triangular bone that lives right at the base of your spine. And then your spine stacks up right on top of that. We have L1, L2, L3, L4, and L5. There's a 5th vertebrae that's not represented here in this model, but you have 5 lumbar vertebrae, you have 12 thoracic vertebrae. Those are numbered T1, T2, T3, T4, all the way down to T12. This little blue dot is the midpoint between the left and the right side of the pelvis of those 2 PSIS bones. So that's the midpoint of the sacrum. And then this red dot is at the vertebral prominence of your cervicothoracic junction. So where your neck interfaces with your torso, the system identifies one point, has a red dot, and then it drops a black line straight down. So that's a perfect vertical or a plumb line. And we use this black line, this vertical line, to look at the torso position in relationship to the sacrum. And we can tell here in Lyndsay that she has a left lateral shift of her torso over her sacrum as she's just standing here. If we want to be more specific, we can come up here to this chart and we can see that the coronal imbalance, which is what this system uses to delineate that metric, is about 13 millimeters. So she has 13 millimeters of a left lateral shift of her torso using that vertebral prominence away from the midpoint of her sacrum. And in a second, we're going to see how that lines up against what we would like to see in people with healthy spines. Something else that we can see is that it looks like this right PSIS is a little bit higher than the left PSIS. We can see that this is not a total horizontal line. So if we come up here to our chart again, we can see that the pelvic obliquity, which is looking at the left and the right PSIS height, is about 4 millimeters off, where the right side of the pelvis is 4 millimeters higher than the left side of the pelvis. Something else that we can visualize here is if we turn this to the side, we can get a sense from these green arrows that the right side of the pelvis is anteriorly rotated a little bit more than the left side of the pelvis. So, and this gets into the kind of the biomechanics of the sacroiliac joints, which we're not going to spend much time doing. But what we will say is that the right side of her pelvis is anteriorly rotated in relationship to the left side of her pelvis by about 4 degrees. What we know is that if we have an anterior rotation of one side of the pelvis, that is going to create a functional leg length discrepancy and make that leg look a little bit longer. So the fact that Lyndsay has 4 millimeters higher of a bony landmark here, and she has 4 degrees of an anterior rotation, those two things kind of go together. What we're looking at here is a representation of rotation, of what's going on at each one of these vertebrae. So we have these numbers over here, T4, T8, T9, T10, T11, T12. That represents all of these vertebrae here in the thoracic spine. Then the lumbar spine were represented down here. And what this is picking up is it's looking at these little bony processes on the back of each vertebrae called the spinous processes. So when we're looking from the back, if one of those spinous processes is deviated off to the left, like we see here, it means that that segment or that couple of segments are rotated to the right. So you just have to kind of wrap your head around that nomenclature. So a left deflection is representing a right rotation. So we can see in Lyndsay that she has a couple of segments right at about T10, and then above it a little bit, below it a little bit, that are in a little bit of a right rotation. Down here in the upper lumbar spine, she has a very, very minor left rotation, and then she has a very, very minor left rotation up in her upper thoracic spine as well. We're going to hold off judgment on the severity of this until we look at a different portion of this analysis, and then we're going to keep our eye on that as we look at her spinal mechanics as she walks. And there was actually one way. Lyndsay, do you remember which way you were stiff? Was it right rotation that you were stiff in?
It was left rotation.
Left rotation.
Yeah.
So Lyndsay remembers being stiff into left rotation when we were doing that 6-week strength and conditioning program. So we'll see if that actually comes across when we look at the dynamics of the spine when she walks. We are going to skip this. This is looking at side bending. She doesn't have much of a side bend dysfunction, so we're not going to spend much time looking there. This is looking at her spine in the sagittal plane. So we're looking at the thoracic spine, and we're looking at the lumbar spine, and we're looking at the normal curves that we have in flexion in the thoracic spine, and the normal extension curves that we have in the lumbar spine. And to get a better sense of where these line up compared to normal healthy spines, we're going to go to a different tab here in our system, and this is going to give us a cheat. So what this has done is it's taken all of Lyndsay's metrics, and it's lined them up on all these different spinal categories against normative data, so what we would consider healthy spines based on the research of Dr. Harsman. So the coronal imbalance, which is that left lateral shift of her torso over her sacrum, over her base of support, puts her very much in the red zone. So she has a 13 millimeter discrepancy, so she's definitely in the red zone. And I am not terribly concerned about this yet. I'm going to be more curious to see what happens as she runs and how she organizes her torso over her sacrum as she is loading the left and the right leg. So this raises my eyebrow, but I'm not ready to call it horrible until we see what happens dynamically. The pelvic obliquity, which is the right PSIS being 4 millimeters higher, puts her in the yellow zone. We don't get very concerned until we're over 7 millimeters. The anterior rotation on the right side is 4 degrees. That puts her in kind of the yellow approaching orange zone. which is something that we would also cross-reference with the clinical evaluation to make sure that she either has the motion in that SI joint, and if she's lost it, then there might be some exercises or some manual therapy that we need to do to improve that. But that puts her in the yellow zone, and we also know that she has a lot of those biomechanical dysfunctions in the frontal plane on that right side. So those probably tie in to what's going on that right side of that pelvis. We pointed out that she had some rotation in her spine, but they're really pretty minor. Those are still putting her in the green zone. The side bending we said was also in the green zone. This is what's called apical deviation in this system. Then the angulation of her spine. The thoracic spine angle for her is about 50 degrees of flexion. That puts her right in the green zone. That's awesome. That's really good. Her lumbar extension is about 56 degrees. And that's pretty excessive. That puts her in the red zone. And we know that she has some lumbar vulnerability when she's running, especially during long runs. And what we could tell from the first layer of interpretation is that when she goes into extension in the backside of her mechanics, because her hip flexors are so tight, that she's getting a lot of that backside push-off from the anterior rotation of her pelvis and the consequential increase in that lumbar extension. So the lumbar extension that she is standing with is likely very much tied to the tightness that we know that she has in her hip flexors because we've done the clinical evaluation. And that also follows the narrative of what happens biomechanically in the backside of her mechanics and why she has low back vulnerability. So that would be a priority for her with a very individualized strength and conditioning and corrective exercise program, which it is. We see her doing some of the hip flexor stuff in the gym, as we already said. All right, so that's where we are, looking at static spinal posturing. And this is important because it starts to give us some information as to what to expect when she starts to move. So let's see what happens when she starts to move. And here we are back to our landing page. So now we're doing a walking examination. We're going to only look at spine and pelvis in this examination. When we get to the running in this second level, the second layer of biomechanical interpretation, we're going to look a little bit more specifically at some things in the sagittal plane. And we're going to look at the 3D spinal mechanics first, and then we're also going to look at some plantar pressure information when we get to the running assessment. But for the sake of this, we're just going to look at spine and pelvis. And we'll look at the spine first. So here we have a lot of the same things that we just looked at statically, but now we're looking at the dynamics of the spine. So we still have our left and right PSIS, we have the midpoint of our sacrum, we have the 3D spinal model, we have the vertebral prominence at the CT junction. We have that black line representing what's going on in that frontal plane or that coronal plane as she's loading left and the right leg. We have the rotation graph, and we have the side bending graph. So we will start with the rotation graph. And what the system is doing is over the course of this study, for every one moment in time, it tells us exactly where the spine is. And then as it goes on to the next slide, it lays down a gray line, which you can kind of see over here. It lays down a gray line to let us know over the course of the entire study what the motion mapping is of the entire spine in the transverse plane or in the rotational plane. And there's a couple things that jump out at me right away. The first one is that, so 0 is totally neutral. So everything to the right of 0 is going to be a left rotation. Everything to the left of 0 is going to be a right rotation. We have a large section of her spine up through here that is getting virtually very little, if any, left rotation. All the way from about, we'll say T4, 5, about T6, all the way down to maybe T11. She has this big area that she's getting very, very little left rotation. And what we know clinically, and also what we know from watching her do her spinal rotation exercises in the 6-week strength and conditioning program, is that she has limited left rotation range of motion. We can visualize that in the gym. And now we can actually measure that with the 3D spinal modeling technology that this raster stereographer is giving us. So this becomes a priority for her. We know that she's not going to rotate very well to the left. If she can't rotate well to the left in those segments when she's walking, she's not going to be able to do that when she's running either. So that becomes a priority for her. And one thing that we're starting to realize, just to back up a little bit, and this is just being highlighted with a lot of my conversations with some of our physical therapy colleagues over in Great Britain that work at a university called Salford that do a lot of research on spinal mechanics. What's becoming very obvious to me and is being reaffirmed by my conversations with them is that what goes on at the spine is really the keystone of what is happening south of that. It can have a huge impact on loading strategies, lower extremity kinematics, plantar pressure stress distribution. So really being able to visualize the spine and fix these small little anomalies in motion, in very specific planes of motion, can have a profound impact on running biomechanics, on decreasing injury potential, improving durability, and improving your mechanical efficiency and your performance potential. So you really can't get this 3D spine modeling in many places in the world. There are ways you can start to visualize it a little bit with an iPad, but this has been integral for us in our understanding of how the spine actually contributes to running mechanics. And we'll talk about that a little bit more when we get to the running assessment. If we look at this side bending graph now, we can see that she's getting quite a bit of left and right side bending. There's symmetry, which is good, but she's getting quite a bit of left and right side bending all the way through that kind of thoracic spine, all the way from about T5 all the way down into the thoracolumbar junction. So this is something that I would want to clean up a little bit. I think that that's a little bit excessive just because I've seen a lot of these tests. So in my mind, this would result in me giving her a lot of lateral plank and a lot of lateral strengthening exercises, in addition to working on some rotation range of motion exercises and some rotational strength exercises. All right, we are now going to go into the pelvis and visualize this. So now as we're looking at the pelvis, we're looking at the pelvis in two planes of motion. We're going to look at the pelvis in the frontal plane or the coronal plane. We're going to look at the pelvis in the transverse plane and its rotation. So what we know is that as our runner loads the right leg, so you can see here that Lyndsay is on the right leg in mid-stance over here in the picture. So as a person or a runner loads the right leg, we're going to get a little bit of a contralateral pelvic drop. We don't want that to be excessive, and we're going to continue to look at that when she's running. And we want there to be some symmetry as well. So for Lyndsay, when she's loading the right leg, she's getting a maximum of 5 degrees of a contralateral pelvic drop. When she loads the left leg, she's not getting any contralateral pelvic drop at all. So 5 degrees in a runner when they're walking is a little bit excessive. 0 degrees, we'd like to see a little bit more than that. However, we know that she has likely a functional leg length discrepancy. That right leg was, I think, 4 millimeters, or at least the right PSIS was 4 millimeters higher than the left PSIS. In that static standing position, you know that the right ilium is anteriorly rotated 4 degrees in the standing position. So her pelvis is already living in a little bit of a left side bend position. So we have to reference that when we're looking at how much motion she's getting to the left and to the right. So I'm going to hold off judgment of her pelvis until we start to look at her running assessment, at least in this frontal plane. When we're looking at her pelvis in the transverse plane as she rotates, she's getting about 5 degrees of maximum rotation to the left, about 4 degrees of maximum rotation to the right. She has good symmetry there, and that's within a range that we like to see. We'll continue to look at that when we get into the running mechanics as well, which is what we're going to do now. So we're going to go to her running assessment. This is 8 miles an hour, and this is what we used in the first layer of biomechanical interpretation that your local running specialist is going to be able to do with their iPad or any other higher fidelity technology that they have. And we come back to our landing page, and now we're going to look at the spine again, and we're going to look at the pelvis again. We're going to start with that. I'm going to unpackage some more specific things in the sagittal plane, and then we're going to look at plantar pressure distribution, and then we're going to wrap this up. So when we go to spine, we'll start with the spine. Then we're going to look at the frontal plane. And we'll just let this roll for a little bit, and we'll get a general sense of what the spine is doing as she's loading the right and the left leg. And then we're going to dig into the numbers a little bit more. All right. So we're going to stop this, back it up. And the first thing that we're going to look at is the coronal imbalance, or the lateral shifting of her torso over her sacrum. And just to remind you, how we're going to measure that is we're going to measure the displacement of that vertical line that drops down from the cervical-thoracic junction. We're going to measure the distance between that and the midpoint of the sacrum. And the system is going to give us not only the millimeters of discrepancy, but also a degree of angulation, which I like to use more so than the millimeters of displacement. So when Lyndsay loads the right leg, which she's doing now, we're going to see that her torso shifts off to the right a little bit. So that's about the maximum right shift that she's getting. So what we want to see visually on our system is that we don't want to see that vertical line go much more beyond midway between the midpoint of the sacrum and the right PSIS. We certainly don't want to see that black line touch the right PSIS. That visually starts to suggest that she's getting an excessive amount of right lateral shift of her torso over the sacrum as she's loading the right leg. So to be very specific and to grab some objective data that the system allows us to gather, if we come up to our data box in coronal imbalance, right now she's in 3 degrees of a right shift. What we have identified with the runners that have come through here in all levels, both our professional runners and our recreational runners, is that we don't want to see much more than 4 degrees of a lateral shift during the loading phase. Anything more than 4 degrees starts to increase the likelihood of injury. And we'll unpackage that here in a second, but let's progress Lyndsay forward and see what happens when she loads the left leg. So as she comes back over and loads the left leg, we now see that she's getting a much more exaggerated left lateral shift of her torso away from the midpoint of her sacrum. If we come back up to our data box, we can see that she's now in 6 degrees of a left lateral shift. And that's excessive. We said that 4 degrees was the high end of normal. Anything more than 4 degrees, we start to get a little bit concerned. She's at 6 degrees. That definitely puts her, in my mind, kind of in the red zone that we need to really address with a lot of kind of lateral plank, lateral core strength and neuromuscular re-education. If we come over here a little bit further into this graph or into this kind of data box, we can see that she gets a maximum of 5 degrees of a right lateral shift when she's in the right leg loading phase, and a maximum of 7 degrees when she loads the left. So she's getting excessive right and left lateral shifting of her torso over her base of support. So we want to fix that. And why is this important? This is important for a couple of different reasons. What we have been noticing in the last couple of years of looking at spinal mechanics in this, especially this frontal plane kind of torso shifting, is that in our female athletes in particular, when they start to get excessive left lateral shifting, and if they're running very high volumes, this is the biomechanical signature of something that ultimately, if left unchecked, can lead to femoral neck stress reactions or bone stress injuries and sacral stress injuries. In our male athletes, we see that this kind of a shift more than often results in SI joint irritation, just because this is really shifting how the upper torso is creating some loading and the need for force dissipation through the leg and the pelvis. So this is something that we look at quite a bit within our lab, and something that we really try to correct if it comes across like it does for Lyndsay as she loads the left leg, and even as she loads the right leg. That's not great. All right. If we come down and look at her rotation, so this is looking at what's happening in the transverse plane. And we know that she doesn't have very good left rotation when she's walking. We know that she doesn't have very good left rotation when she's doing her exercises. And what we can tell here is that she gets about, she's getting less rotation to the left. So that's something that we just had kind of reaffirmed is kind of feeding into her running mechanics as well. We already know that we're going to make that a priority because of what we saw in her walking assessment. Last thing we're going to look at in the spine is we're going to turn this to the sagittal plane. We're going to let this roll for a little bit. And this is really a remarkable quality of the spine and how it functions in the sagittal plane for runners. We know that cheetahs can really use their spine as an elastic recoil apparatus, basically as a spring, to really help their velocity and to help their mechanical efficiency when they run. Even though we are bipedal, we're running on 2 feet and we're not running on 4 feet like cheetahs, the spine has the same capability of functioning as a vertical leaf spring. So how does this work? How this works is as the runner comes down to the ground, so they are now kind of in mid-flight, as she comes down to the ground and she makes initial contact, from initial contact to mid-stance, her thoracic spine, this part right here that has a natural flexion bow to it, is going to increase that flexion. So the spine is going to flex a little bit as she lands. That flexion or that bowing, the energy there is going to be stored in some of the viscoelastic properties of the intervertebral discs that live in between each one of the vertebrae in this really big, durable, elastic structure called the posterior longitudinal ligament. So the spine is going to bow and store that energy so that from initial contact to toe off, the spine re-extends a little bit and some of that stored energy is returned into the ground during the propulsive phase. So what we know in looking at a lot of our runners is that over the course of the entire running test, we want to see about 10 degrees of thoracic flexion extension excursion. And Lyndsay is close to that. She's from 37 degrees to 49 degrees, so she's a little bit higher than that. But that's within a range that I think is pretty healthy. It's not excessive, it's not limited, it doesn't seem like it's excessively rigid. So to me, it seems like her thoracic spine is functioning pretty well in the sagittal plane as a plyometric apparatus. If she was very stiff, then there might be some things that we would want to do to help improve the thoracic spine. Her lumbar spine has kind of a slightly different phase. We get peak lumbar extension when she is at toe off. So as she pushes off in the backside of her mechanics, which is right about here, and we can actually see that if we come over here and we look at this graphical representation, the red line is where her spine is at this very moment, which is right around mid-stance for her. As we go from mid-stance to toe off, we're going to see that her angle, which right now is at 32 degrees, is going to come up closer to 42 degrees. So we're going to progress forward frame by frame, and we're going to see that her lumbar extension angle, as she goes from mid-stance to toe off, increases. And that's natural, and that's normal, and that's what we would anticipate seeing. We do know that Lyndsay gets a little bit excessive. She's already living in excessive lumbar extension range of motion. And we know that at toe off, she's getting excessive lumbar extension excursion as well. So we've already identified that from the lateral view. This just allows us to put some numbers around it. And now we're going to look at the pelvis. So as we're looking at the pelvis, and we can actually just visualize now that we're looking at her run, and if we look at that lateral shifting of her torso over her sacrum, we can see that she's getting a lot of lateral play. So this is something that you can kind of visualize with an iPad. It's something that you probably can't accurately measure with an iPad, but you can get this sense of this excessive lateral shifting in a runner, and we can actually kind of visualize that she's getting more left lateral shift in many of the strides than she gets right lateral shift as she loads the right leg. But as we start to look at her pelvis stability, so we're looking at how well she maintains kind of a horizontal pelvis. That's what we're looking at here in the frontal plane. And as she's loading the right leg, now she's getting about 3 degrees of a contralateral pelvic drop. As she loads the right leg, she's getting 4 degrees of contralateral pelvic drop. As she loads the left leg, she's getting about 3 degrees of contralateral pelvic drop. That looks to be pretty healthy to me, so I'm okay with that. In rotation, Lyndsay's getting about 7 degrees of left rotation. She's getting about 5 degrees of right rotation. That is good symmetry, and that's within a range that we would like to see as well. To unpackage this a little bit, we're going to stop this, and we're going to go to a peak left rotation. So we're going to come over here and look at this graph. So 0 is when her pelvis is totally neutral in the transverse plane. Everything north of that is a right rotation. Everything south of that is a left rotation. So here's a peak right rotation, peak left rotation, peak right rotation, left, on and on. We'll come over here to one of the peak left rotations in the 4th stride of her study, just to get a sense of how the pelvis is phasing in relationship to foot contact. So here we are going from neutral into left rotation. And to get a sense of where left rotation is really starting from neutral, we are going to go to the left lateral view, and we're going to see that she is in initial contact. So as soon as she makes initial contact, from initial contact through mid-stance, her pelvis is going to go into a little bit of a left rotation. A little bit of a left rotation is appropriate. That's what we want to see. We don't want to see excessive left rotation as she goes from initial contact to mid-stance. That to me suggests some rotational core strength inadequacies. We also don't want to see a lot of stiffness. And one thing that we're starting to see in our runners that have anterior femoral acetabular impingement syndrome, which is an anterior hip impingement that you can have a predisposition because of some architectural defects of the joint, is that they get very limited rotation from initial contact to mid-stance, which to me seems to be a protective mechanism to help prevent that anterior impingement. And if that's the case, then we need to improve the rotational range of motion. If it's too much, we need to limit the rotational range of motion. So this becomes really important. If we go forward, we can see that she ends that left rotation and starts to go back in towards right rotation in the backside of her mechanics. So as she goes forward, what we would like to see from a phasing standpoint, and we'll go to the left, is that as she is in toe off, what I would like to see is I would like to see the pelvis at toe off return to neutral. And she's a little bit lagging behind that. I would like to see her pelvis right about here in neutral. So I still might want to give her some rotational core strength just to optimize that pelvic rotation, not necessarily from a range of motion standpoint, but from a phasing and a sequencing standpoint. All right, I know that's complicated, but I'm sure that my physical therapy colleagues are following me, and you can lean on their intelligence to help you improve that if it's an issue in your running mechanics, or if it's something that's predisposing you to some injury. All right, I told you that we were going to go back to the lateral view, and we were going to look at something. We'll go to the right side. So we had talked about during the mid-stance, so we're going to go to mid-stance, which as we said was where we hit peak knee flexion. So we're going to go to peak knee flexion, which is 46 on this right side. So she is now in peak knee flexion. She's in mid-stance. If we look at peak knee flexion as mid-stance, 46 degrees, and we look at the ankle dorsiflexion range of motion at that point, we can see that it's 12 degrees. Now, I had said in the first level of interpretation that we can use an iPad for that it's really hard for me at least, and maybe some of my physical therapy colleagues, if you see this and you have a different opinion, send me an email and send me some literature. It's hard to say that there is a definitive range that is healthy and not healthy for ankle dorsiflexion at mid-stance. I just see a wide variety between my runners. Some have very, very little because they're able to use their gastroc-soleus complex as a very, very competent plyometric tissue, and others that have a lot of ankle dorsiflexion. And this is even in my Nike runners, some of the best runners in the world. Some of my really, really fast 800-meter runners have very, very little ankle dorsiflexion at mid-stance. And some of my runners that are 5K, 10K athletes that are the best in the world at that discipline have a lot of ankle dorsiflexion. So I haven't identified a range that I really like. What I have identified, however, is that I want there to be synchronicity between knee and ankle mechanics from mid-stance to toe off. And what I mean by that is from mid-stance, as we go forward, Lyndsay is going to be going into the propulsive phase of her running cycle, which means that she is going to start to go from knee flexion to knee extension. What I would like to see is that as she starts to drive out of knee flexion into knee extension, into the backside of her mechanics, that the ankle is in synchrony with that, so that she doesn't continue to go into ankle dorsiflexion as she goes into knee extension or she comes out of knee flexion. I want to see that as this number decreases, this number also decreases. So she's at 46 degrees of knee flexion. She's at 12 degrees of ankle dorsiflexion. We're going to go one slide forward, and we can see that she is going into knee extension because now she's in 45 degrees, and her ankle is now in 15 degrees of dorsiflexion. So she goes from 12 degrees of dorsiflexion to 15 degrees of dorsiflexion. So she is still collapsing through ankle dorsiflexion as she's driving through her knee. If we go one more slide forward, she continues to go into dorsiflexion. So there's not very good synchronicity between the knee and the ankle. And what that has been showing me clinically is that this puts a runner at a significant increase in the likelihood of developing Achilles tendinopathies or tibialis posterior tendinopathies, which is on the medial side of the ankle, plantar fascia issues, and anterior talocrural impingement issues. I have runners come in here that say that they feel like their ankle is jammed up because when they run, they get a lot of anterior jamming. And the inclination is for them to want that joint loosened up. But what I'm finding more often than not is that it's not a range of motion issue, it's a strength issue. And it's the lack of strength that's causing an asynchronicity, which is causing excessive dorsiflexion collapsing in the backside of the mechanics, which is creating the jamming in the front of the joint and the excessive length tension relationship in the Achilles. What we have identified that we have not substantiated yet with research is, which we will do because we also have surface EMG capabilities that plug into this entire system. We just haven't really been looking at that closely yet. It's my assumption that it's soleus weakness that is preventing the lack of the dorsiflexion deceleration. So with our runners, when I see this asynchronicity, I really attack soleus strength more so than gastroc strength, and we have been seeing a shift back towards better synchronicity and less of an ankle dorsiflexion collapse. It's my assumption that from initial contact to mid-stance, the soleus is primarily responsible for decelerating dorsiflexion. And then from mid-stance to toe-off, it's the gastroc, which is a biarticular muscle which crosses the back of the knee joint, really starts to create a lot of the strength to create that heel off in the propulsive phase. So again, my physical therapy colleagues, if you have any research to substantiate that, if you have any thoughts, please email me. I'd love to hear your thoughts. And if you're not biomechanically inclined, you're not a physical therapist, lean upon your local running experts to help you figure out if that's something that you need to improve upon. Something else that we will look at in this view, and this has a little bit to do both with performance optimization and also injury predisposition. And then after this, we're going to get out of the slow motion video analysis and look more specifically at plantar pressure information. So at initial contact, which we're going to say is right about here, Lyndsay's hip is at about 19 degrees of flexion away from vertical. What we would like to see, and what we see in most of our professional runners, especially our healthy professional runners, is that once hip extension is initiated, it continues all the way through toe off. What that means is we're going to come up here to this graph to look at that, and I'm going to go forward a few. So 0 is when the hip is directly underneath the runner. Everything north of 0 is hip flexion. Everything south of 0 is hip extension. So we are going to progress this gold line until we get to peak hip flexion, which is right here, which will be the front side of her mechanics on the right leg. So here we are in the front side of her mechanics on the right leg. So that is peak hip flexion for her, which is 38 degrees. As we go forward, we're going to see that the hip starts to extend. 34, 31, 29, 26, 22, 20. In our professional runners that don't have any hamstring irritabilities, what we'll see is that extension continues all the way through to toe off, even though the rate of extension will change a little bit from initial contact to mid-stance. What we see in Lyndsay here is that as she makes initial contact, this line actually goes back up towards flexion before it then starts going back down into extension. So what we'll see is that she's at 18 degrees of flexion. We go forward, she's at 17 degrees, 16 degrees, 15 degrees, 14 degrees. So 14 degrees, then she goes into flexion, then she goes into more flexion, and then she starts to go back into extension. So in our professional runners, or even in our recreational runners that don't have the tendency to get high hamstring tendinopathies, extension will continue and they won't have that little flexion moment at initial contact to mid-stance. That just puts a big eccentric load through the hamstring, which hamstring tendons don't necessarily like. So for Lyndsay, I would want to improve that because it's going to rob her of some of her mechanical efficiency, but it's also, in my mind, going to leave that high hamstring tendon a little bit vulnerable for an overuse tendinopathy. Okay. Complicated biomechanics, but stuff that I'm pretty compelled by and that I know a lot of my physical therapy colleagues are also compelled by. All right, now we're going to look at plantar pressure data, and then we're going to wrap this up. So here we're looking at pressure plate data in our high-speed treadmill, and we're going to look at a couple of different tabs up here. So the first one we're going to look at is this graph right here, which is going to give us some pressure information, but also give us some information about how Lyndsay's center of pressure progresses from initial contact through mid-stance and into toe-off. And this is what's happening kind of in real time. And this is an average of that. So we're going to look at the right side and we're going to look at the left side. We can tell that both on the right and the left side that she is a heel striker. She's landing on the left lateral side of the left foot and the right lateral side of the right foot. As she goes from initial contact to mid-stance, she gets an immediate anteriorization of her center of pressure, which is what we want to see. As she goes into mid-stance, kind of full contact of her foot, she goes into a little bit of medialization of her center of pressure. That's a little bit of pronation, which is appropriate. We want to see a little bit of pronation. Pronation isn't bad. It's how the arch helps contribute to the vertical attenuation of your impact force. And then as soon as she hits kind of that peak pronation, she'll start to get a little bit more pronation, but then anteriorization of her center of pressure as she goes into toe off. This looks pretty good on the left side. On the right side, she has a lot more medialization of her center of pressure, which means that she's pronating more on the right side from the pressure plate data. We know from the slow motion video analysis, when we look at the posterior view, that as she loads that right leg, she gets a lot more calcaneal collapse and a lot more of an Achilles angle, which we know is being driven by an inward collapse of the arch or excessive pronation, which is excessively loading that tibialis posterior and making this right Achilles vulnerable. We know that she has tibialis posterior vulnerability during her long runs, so what we're seeing here in the pedo gait is just adding to that narrative, that she does have some tibialis posterior weakness potentially. Definitely this is being influenced by the kinematics of that entire right leg. That whole right leg goes into a lot of collapse in the frontal plane, a lot of internal rotation impulse. It's taking the foot with it. It's putting a lot of load on the tibialis posterior, which is what's being represented here. Lyndsay has a very interesting strategy to try to prevent that. And we'll look at this a little bit more closely when we look at a different tab. But as we're here in this graphical representation, what we'll see as she progresses into toe off, and we'll start back here, is that we start to see a lot of high pressure. So red is high pressure. Here is our pressure gradient. Red is high pressure. So right now, when she's a little bit beyond mid-stance, she has very little pressure through the big toe and through her forefoot. Look how much pressure she has through the big toe already. And if we go forward frame by frame, we can see that she's really jamming that big toe into the ground. So the reason that she's putting a lot of pressure into the ground of that big toe is she's trying to use her big toe flexion strength, and primarily the flexor hallucis longus, to try to create some midfoot stability because she's not getting it from the tibialis posterior alone. So this, over the course of time, can cause a flexor hallucis longus tendonitis, which will kind of create symptomology similar to either an Achilles tendonitis or plantar fasciitis. It can also cause big toe joint soreness, which Lyndsay gets some of during her long runs. So this seems to be a compensation for using her big toe strength to try to prevent this excessive pronation. If we look at a different variation of that, so here we have taken her foot and we have compartmentalized it into big toe pressure, lateral toe pressure, first, second, third, fourth, and fifth metatarsal pressure, midfoot pressure, and then medial and lateral rear foot pressure. All of these color codes get brought over into these graphs so we can look at big toe pressure distribution from initial contact to toe off. We can look at the magnitude of pressure in newtons. And then we can look at metatarsal stress distribution. And we can look at midfoot stress distribution and calcaneal stress distribution, medial and lateral. These graphs are an overlay of all of these. So we can look from initial contact to mid-stance, what part of the foot is loading, and the magnitude of loading of vertical force measured in newtons of those sections of the foot. So we said that the big toe on the right side was taking on a lot more force than on the left side, and that it was starting to put more force earlier in her gait cycle. And that's what we can actually see here. So we can see that on the left side, she'll start to put some force, or she'll start to get an increase in the force like after 87 milliseconds. Here she's getting an increase in the force right in between 43 and 87 milliseconds. So she's loading earlier and she's loading more. We can see on this left side that she's getting a little bit more than 100 newtons of force. On the right side, she's getting close to 200 newtons of force. If we want to be very specific, then we can actually go through and see that she's putting a maximum of about 117 newtons of force through the left big toe, and she's putting a maximum of, that was 168, we'll go back here, 173, 174, so about 174 newtons of force through the right big toe, and it's a lot earlier, that peak force is a lot earlier in her contact. So just another way to kind of look at that and to see that there is some flexor hallucis longus and some big toe vulnerability, likely as a compensation for what's going on through that pronation impulse as she's going into the loading phase. Something else we like to look at in pressure distribution is metatarsal stress distribution. We know that runners that do a lot of miles get a lot of metatarsal loading and have a predisposition to metatarsal stress fractures. If we saw a distribution where the second or the third metatarsal had a higher peak load than the first metatarsal, that would be something that we would want to correct by getting them in the appropriate footwear and potentially making them an orthotic. Normally, footwear does a better job of this and we really don't need to lean on orthotics that much. Another interesting thing in Lyndsay is if we look at her metatarsal stress distribution, we look at how much more fifth metatarsal stress she's getting than on the left side than the right side. On the right side, she's getting virtually none. On the left side, she's getting probably close to 50 newtons. What we know is that in mid-stance, Lyndsay gets a lot of left lateral shift of her torso. So we'll go back to that and we'll look at that. So here we are. She's in mid-stance. Right now, she's getting 6 degrees of a left lateral shift. So the center of mass of her torso in relationship to the base of support, which is her left foot, is going to shift where she's getting load through the metatarsals. So when we have athletes that come in and they're getting a lot of lateral foot pain and lateral foot irritation and potentially fifth metatarsal stress reactions or stress irritabilities, we're starting to see that it's less of a foot dysfunction and more of a spine and torso dysfunction. And it's that excessive lateral shifting of their torso during peak vertical force attenuation in mid-stance that's shifting load onto the fifth metatarsal that's causing that irritation. So this is something that I think is easy to conceptually want to chase with orthotics and with foot strengthening. But if you don't correct the origin of the dysfunction, which in Lyndsay's case is poor spine stability strategies in the frontal plane, then she's always going to get excessive fifth metatarsal loading dysfunctions on that left side. We can also go into looking at step length, step time, stride length, all these other parameters of gait, which we're not going to necessarily do for the context of this biomechanical analysis. So that's a lot of information. That'll probably end up being about an hour-long video, which is similar to how long the strength and conditioning videos were. So hopefully you get through at least the first phase. If you're interested, then congratulations, you got through the second phase, which was a lot heavier in the biomechanics. Keep sending us questions, keep sending us comments, keep sending us requests. We're having a really good time developing this content and just sending it out to all of our running community across the world. So we'll keep developing content as you keep asking us to give you more information. So thank you very much for following us, and thank you for watching our videos.